All right, guys. So last time we were just looking at a bunch of questions regarding the physiological changes that occur in pregnancy, right? So great stuff. All wonderful questions to help you really see how physiological things are going to show up and when things are actually not physiological and you need to do something, right? So like this question right here, we had to do an echo, even though 35% of people incorrectly chose reassurance and routine care. This was not a reassurance question. We left off after looking at this fetal tachycardia question where the patient had pyelonephritis, a very common complication that occurs in pregnancy due to the various changes that I've bolded out for students so that you can all actually get a good understanding of what is happening. Now, moving on, there's a bunch of there's a bunch of random things you're going to be hearing about as you keep going with the aspect of pregnancy and changes that occur. For example, this one here is showing that in 32 weeks of pregnancy, the appendix kind of seems to move up, right? So the appendix during pregnancy, just a quick little picture, just to show you where things are. It's really not something that you have to know for life or something like that, unless you're going into OBGYN. But it's an interesting little thing, right? So that picture was there, so I just put it right there. It's a normal thing for the appendix to be up there, all right? Now, here is a little bit of fact for what pregnancy should involve in terms of exercise. You'll get some questions oftentimes where it might be about how much exercise a pregnant woman is doing and what's appropriate, what is not appropriate. So generally, 20 to 30 minutes of moderate intensity exercise on most or all days is recommended. Exercise during pregnancy is associated with a decreased risk of gestational diabetes, preeclampsia, and cesarean delivery. Thus, low-risk patients who exercise regularly prior to pregnancy are encouraged to continue moderate intensity exercise during pregnancy. Advanced maternal age and prior cesarean delivery are not contraindications to exercise. Very important to remember that. Questions will often try to push things in a way where it makes it look like it's a contraindication or it's a bad idea or something bad is going to happen, but in all reality, it's not a problem at all. Avoid exercise in patients with the following. So this is where it is bad and you should not have a pregnant person exercising. 1. At risk for preterm delivery due to cervical insufficiency, preterm labor during current pregnancy, or preterm premature rupture of membranes. Rupture of membranes, premature rupture of membranes is PRON, often referred to as just PROM, and PPROM is preterm PROM. So those are all people you definitely don't want to recommend exercise to. Number 2, at risk for antepartum bleeding due to placenta previa or persistent second to third trimester bleeding. Again, should not be exercising. And then number 3, with underlying conditions that could be exacerbated by exercise, such as severe anemia, hypertension disorders like preeclampsia, restrictive lung diseases, or even severe heart disease. And this list for number 3 is much longer than that. There's a lot of things that should make you think, oh, yeah, this person probably shouldn't be exercising. Right? In addition, exercise that has risk of blood trauma or falling should be avoided, of course, because you're pregnant. If you fall, you could have a miscarriage. Like contact sports, gymnastics, skiing. These are definitely not things you want to do when you're pregnant, right? So those are just some key facts regarding all of that. There's a table here for pregnancy and exercise. There was probably a question regarding this, but it was probably a really easy question. So I most likely didn't have space to fit it in here, but I got the table and the notes down, right? So it makes sense. So unsafe exercises are all of these things that you definitely don't want to be doing when you are pregnant. And absolute contraindications to exercise during pregnancy are these things, right? Because if you exercise and you have that increased intra-abdominal force, increased pressure on your legs, increased pressure on your heart, these things can get further worse, right? Down here we have a question about syphilis in pregnancy. So a huge topic. 24-year-old woman, G1P0, at 31 weeks gestation, comes to the urgent care due to a rash on her back. So this is her first pregnancy. Her mom first noticed a small rash on her back a week ago, and it has spread despite the use of topical cream. She has had no prenatal care, vitals are normal, fetal heart rate is good, fundal height is 28 centimeters. The rash extends across her trunk and extremities, including the palms of the hands and the soles of the feet. The lesions do not bleed, and there are no excoriations. The rash is seen in the image above, so it looks like this. What is the most likely diagnosis in her? Now, people were all over the place. The correct answer was this is actually secondary syphilis. So 35% of people correctly picked that. But 30% of people chose pityriasis rosea, which is a thing from dermatology. and 25% of people chose polymorphic eruption of pregnancy. All right, so what's happening here? Her maculopapular rash. This kind of looks like something you would use ketoconazole for, right? It kind of looks like ringworm almost in a sense, right? So her maculopapular rash involving the trunk, extremities, and most importantly, right? So they tell you this in the question, yeah, including the palms and soles of the feet, right? You can see that, right? So her rash is including the palms and soles of the feet, and that was the thing that was supposed to ring a bell for you, a really loud bell for you, because there's a mnemonic for this. There's the CARS mnemonic, right? CARS mnemonic, which is Coxsackie A, rickettsia, and syphilis. These are the main guys that cause a rash on the palms and soles of the hand and the feet, right? Nothing else ever causes a rash in those areas. So they tell you this in the question, that the rash extends all the way to the palms of the hands and the soles of the feet. So her maculopapular rash involving the trunk, extremities, and soles is most likely due to secondary syphilis, because it's not Coxsackie A and it's not rickettsia. She doesn't have symptoms for those things. Primary syphilis typically causes a painless chancre that can go unnoticed. Untreated, primary syphilis progresses within weeks to months to secondary, which typically causes a diffuse maculopapular rash due to widespread circulation of Treponema pallidum. The rash usually begins along the skin cleavage lines of the trunk and extends to the extremities, including the palms and soles, which is the main giveaway. Since Treponema pallidum can cross the placenta and cause congenital infection and fetal demise, all pregnant patients are screened for syphilis at the initial prenatal visit, and repeat third trimester screening is indicated in high-risk patients, such as this young woman with limited prenatal care. Treat with intramuscular penicillin G, benzathine. Now, we know that we need to treat this with penicillin, and syphilis was a huge topic way back in step 1 as well. So if we go back to revisit the complete understanding of syphilis, let's see, pallidum over here. So here is where we see the rickettsial and vector-borne diseases, where they mention the CARS mnemonic, right? So CARS, you drive cars using your palm and soles. And then rickettsia is mentioned right here with the whole concept of VDRL false positives, such as even pregnancy, viral infection, drugs, rheumatic fever, and lupus and leprosy. And then the idea of Jairus-Hersheimer reactions, where you get a flu-like syndrome after killing all the spirochetes because they release all these toxins, right? So those are some key things to keep in mind. Now, as far as syphilis itself is concerned, right, you can cause congenital syphilis, which is a really big problem, right? Because it actually does cross the placenta, so that's something that you have to be very careful with. Treat all forms of syphilis with penicillin, and if the patient is allergic, desensitize them, especially in the case of pregnant women. Tetracyclines are the other option, but you can't give tetracyclines to a pregnant woman because tetracyclines are also teratogenic, right? So that's something that you can't really use in a pregnant woman because it's just not going to be useful there. You'll mess up the baby. So very key things to keep in mind for this topic, right? They went on to explain polymorphic eruption of pregnancy presents as a pruritic erythematous papules in the third trimester, but this rash starts within the abdominal striae and the palms and soles are spared. Right, so left and right are both images of polymorphic eruption of pregnancy. As you can see, it just looks like really red stretch marks, right? So very key thing to keep in mind. Then I have a table here for acute fatty liver of pregnancy. This is not exactly a physiological thing. This is fatty liver disease, and it's occurring in pregnancy. So the explanation for this table and the breakdown for this concept, clinical features are going to be nausea, vomiting, right upper quadrant pain, fulminant liver failure. So you're going to see all the symptoms of liver failure because you're going to be lacking coagulation factors. You're going to be lacking your albumin, right? All the things that your liver is supposed to make are not going to be working. So that's really bad. People get profound hypoglycemia because your liver is where you have all your glycogen storage. You get elevated liver enzymes 2 to 3 times above the normal limit, high bilirubin, thrombocytopenia, which is because of lack of platelets, and DIC, disseminated intravascular coagulopathy. Management involves immediate delivery, which is the answer you'll have to pick. So I explained here that acute fatty liver of pregnancy is a rare but life-threatening condition that develops in the third trimester, particularly in patients with multiple gestation. Acute fatty liver failure of pregnancy is an intrinsic hepatic disease, likely due to defective maternal fetal fatty acid metabolism. It causes hepatic inflammation and subsequent fulminant liver failure with profound hypoglycemia. As AFLP progresses, patients can develop multi-organ system failure, DIC, and acute kidney injury from hepatorenal syndrome, which is a pretty big topic in CK. Not so much of a big topic in step 1, but hepatorenal syndrome is tested in CK. As the mom decompensates, the placenta hypoperfuses. Due to high maternal and fetal mortality rates, AFLP is managed with maternal stabilization and immediate delivery regardless of gestational age. Right? Need to get that baby out. Here's another page of more questions, so let's keep going with it. This one here, first thing we see is physiologic hydronephrosis of pregnancy. Another physiologic thing that you need to make sure you understand. All right, so a 24-year-old woman, G1P0, it's her first pregnancy. At 26 weeks gestation, comes to the office due to increased urinary frequency and back pain. For the past 2 weeks, she has had to urinate almost hourly during the day and has awakened multiple times each night to void. So we already talked about this last time, right? We discussed that this multiple times of increased urinary frequency is a pretty common normal finding in pregnant women, and so is back pain because you're literally lifting a heavy thing all day, right? So back pain is normal too. There's all kinds of pain that are normal. The round ligament pain of pregnancy is normal. When we were looking at it yesterday, we saw that the size of the massive uterus kind of presses down on the bladder, right? Just because of the way things are positioned. In fact, here, this is an even nicer image where you get to further understand the exaggeration of things when you have a twin pregnancy, because you can see this is a woman that's laying on her back, right? Her rectum is going down here in the back. This is the exit for the baby path, and then the bladder right there. You can see that when she stands up, both of these babies are going to heavily be pressing down on that bladder. She's going to be urinating every second there's something in her bladder, right? Nothing's going to sit in her bladder for any longer than a few minutes, because as soon as she stands up, she's going to want to go ahead and void all that urine. Another picture was this one with a singular pregnancy. So you can see that the baby is kind of putting weight on both things, heavily on the bladder when the mom is standing and heavily on the rectum when the mom is laying down. Right, so all kinds of things can occur. You can get constipation because of impeding on the rectum, and you can get urinary frequency because of squeezing down on the bladder. So pregnant women urinate multiple times a day. This is the other reason why during preeclampsia you have to do a 24-hour urine collection, because if you just take one session of urination, it's probably gonna be a tiny bit that just came out because it was there, but it won't be a lot of urine because their bladder doesn't really hold a lot of urine. There's no space for that. She has also developed back pain and occasionally has a sharp pulling pain in the right groin. That pulling pain is called the round ligament pain, which is a very normal pain in pregnancy. That's completely physiological. She has no pathological things, which are nausea, vomiting, dysuria, or hematuria. She also doesn't have these pathological things. She has no vaginal bleeding, leakage of fluid, or contractions. Fetal movement is normal. She has had recurrent nephrolithiasis outside of pregnancy, so she gets kidney stones. Now here they are trying to play around with you. Kidney stones are never a good thing, right? They're trying to play around with you though, but you know that right now her symptoms have nothing to do with kidney stones, because kidney stones are a little painful, especially once it goes down the ureter. It's literally just screeching through your ureter and it's going to hurt. Temperature is alright, 130/80, blood pressure, pulse is fine. There is tenderness to palpation throughout the lower back and along the paravertebral muscles. So that's a little concerning, slightly concerning, this tenderness that she has, alright? Lab results, serum chemistry, creatinine is 0.6, urinalysis, everything looks okay, looks like S-ray is negative. Renal and pelvic ultrasound of the mom reveals bilateral enlargement of the kidneys. Right? So her kidneys are getting big, which is the hydronephrosis. The right kidney is larger than the left. There is dilation of the renal pelvis and proximal ureter on both sides. What is the best next step in her management? Now, they could have spent more time talking about more things, more details, more specifics of the ultrasound, and so on and so on. But the point here is that whatever's happening to her is completely normal. These are physiologic things, because if there were pathological problems, you would see at least one red flag symptom. She hasn't had any. There are absolutely zero red flag symptoms. I mean, her kidneys must be working because all she has is trace protein, which we said that in pregnancy, trace protein in the urine is normal. Right? You have to understand that nothing is working at optimal capacity in a pregnant woman because she's putting in all her work and just developing that baby. So the kidney isn't exactly working 100% perfectly either, and some protein will leak out. No additional management indicated was the correct answer that only 40% of people picked, less than 50. 25% of people fell for this question and thought there was something wrong and chose cystoscopy with ureteral stent insertion. Right? But does she really need stent insertion? When do we do stent insertion? We do ureteral stent insertion in someone who is unable to pee, because we need to get that urine out. Right? We need to get that urine out. All that urine sitting in the bladder also makes grounds for more chances of infection. None of that is her problem. She's urinating all she wants to. She has urinary frequency, not difficulty urinating. She has non-specific common symptoms of pregnancy, including urinary frequency, nocturia, back pain, and round ligament pain, which is the sharp pulling pain that she was talking about. Although her exam is benign and her lab results are normal for pregnancy, a renal ultrasound can be performed due to her recurrent lympholysis in her history, right, outside of pregnancy. Her renal ultrasound findings are consistent with physiologic hydronephrosis of pregnancy. During pregnancy, kidney enlargement occurs because there is an increase in maternal blood volume that requires increased renal filtration. Right? We talked about this last time, that there's a really high plasma volume, cardiac output goes up, heart rate goes up. There's a lot happening with that. So if you have more fluid to work with, you need more kidney function, but you don't develop more kidneys, so you just got to make your two kidneys bigger, and in doing so, you get a little bit of trace proteinuria. Hydronephrosis begins during the first trimester as high progesterone levels cause ureteral dilation. Same explanation that has been happening over and over, right? Progesterone related ureteral dilation. And so that's the same explanation for this as well. And decreased peristalsis. Hydronephrosis becomes more pronounced in the second and third trimesters as uterine enlargement compresses the ureters at the pelvic brim, as you can see. This thing is going to keep getting bigger and bigger, and is going to start squeezing into this bone. So it's going to compress the ureter, right? And you know that the bladder is under here, under this heavy uterus. So it's a bit of a problem. It's a bit of a problem for women. Right hydronephrosis is more pronounced due to dextro rotation of the uterus, which causes increased compression of the ureter. Right, so dextro rotation. Dextro is right side rotation of the uterus. Unlike pathologic hydronephrosis, which is secondary to obstruction or infection, physiologic requires no management. Her urinalysis is negative for anything really bad, no blood, doesn't have unilateral findings, so stents and nephrostomy tubes are unnecessary. If anything, they'll be even more bothersome for her. Right? It's really important to understand this concept here. All of these concepts, really. Moving on, here we are at another question regarding ultrasound. So 26-year-old woman, first pregnancy, comes for her prenatal visit. She did not keep accurate records of her menstrual periods, but the last one was about 7 months ago. That's a long time ago. Early in the pregnancy, an ultrasound showed that she was about 6 weeks gestation, giving her a current gestational age of 32 weeks. Her blood pressure is 110/60, pulse is fine. On exam, fundal height is 26 centimeters. Okay. Fetal heart tones by Doppler shows a rate. Okay, so fetal heart rate 140, that's fine. An ultrasound is performed and calculates her gestational age as 28 weeks based on fetal biparietal diameter and femur length. So they're coming up with confusing gestational ages, right? We were at 32 weeks and now we're at 28 weeks. They're not sure. 32 weeks from her ultrasound. Ultrasound gave 32 weeks. And then ultrasound is performed and calculates the gestational age today, and it's 28 weeks, right? Based on fetal biparietal diameter and femur length. So now at this point, you know, compared to early in the pregnancy, this point probably has a better estimate of what her gestational age is, and we'll see. The measured fetal abdominal circumference is consistent with a gestational age of 26 weeks. So now we're even more confused, right? 26, 28, or 32. What is the most accurate method for estimating the current gestational age? So it turns out that this is something you have to know, and we spoke about this very lightly last time. The first trimester ultrasound is the most accurate method for estimating the current gestational age. A lot of students have this logical thinking that I was just giving you earlier. It was false thinking that the later you do this ultrasound, the more accurate you'll get to see the age of the person because they've developed more. Right? This is a very commonsensical kind of thinking, but it's unfortunately incorrect. That if you look at a single cell, you can't really tell exactly how old it might be, you know. Or if you look at a clump of cells, you can't tell how old it might be. But if you look at a completely developed baby, you would know how old the baby is, right? That kind of a thinking. But that's incorrect. First trimester ultrasound is the most accurate method for estimating the current gestational age. After that, the development of every single person is different. See, you have to understand that in the beginning, think about it, one cell becoming two, two becoming four, four becoming eight is the same for all of us. All of us that are watching this video, we all were just like that in our first few cells of life, right? Later on, just think about when you were age 1, age 2, age 3, we all look different. None of us look the same, right? And even now, today, we all have different heights, we all have different body mass indexes, we all look different. So if we were to look at the 1, 2, 4, 8 cell point, we would know the age of those cells no matter who we looked at among all of us watching this video. But if we were to look at all of us right now, there's no way to really predict with accuracy our ages. There would be a lot of discrepancy, right? So looking at it at an earlier age is when you can figure out what the age is, you know. So a newborn you can tell is newborn, 100% confirmed. But a 1-year-old, you can't really tell if they're 1-year-old, 9 months old, or 13 months old, 15 months old. They all look about the same depending on their development. Development skews the accuracy in pinpointing age, right? So ultrasound is commonly used to estimate the gestational age of pregnancy. First trimester ultrasound with crown rump length measurement is the most accurate method of determining gestational age. It becomes less accurate as the pregnancy progresses, as there is minimal variability in size among fetuses during the first trimester. Right, so during the first trimester, we all look the same. That's why it was so easy. The accuracy varies from plus or minus 3 to 5 days between 7 to 14 weeks gestation. If an ultrasound in the second or third trimester shows a discrepancy between estimated gestational age and fetal measurements, as in her, growth problems should be considered. The estimated gestational age from the first trimester ultrasound should not be changed, as it is more accurate than ultrasound estimates in the second or third trimester. So this means that she has a problem, right? Because her ultrasound, let me see, early in the pregnancy, an ultrasound showed that she was about 6 weeks gestation, giving her a current gestational age of 32 weeks. So right now, if I measure again, it should look like it's 32 weeks old, but it's not matching. That means that the baby is not developing well, the fetus is not developing well. After the first trimester, fetal abdominal circumference, biparietal diameter, femur length, and head circumference are used to estimate gestational age. After 20 weeks, fundal height can be measured in centimeters. This is done by measuring from the pubic symphysis to the top of the fundus, like this. This measurement correlates with the gestational age, plus or minus 3 weeks. Fundal height can be confounded by leiomyomata or, of course, obesity, so it is less accurate than ultrasound dating. Right? Because leiomyomata are those little cancerous things you get inside, and they can, of course, cause changes in shape. So, really important to remember that the first trimester ultrasound is the most critical one. That gives you down a timeline to follow and a timeline of development that the baby will follow. And if after a certain amount of time the baby is no longer following that same timeline, then there must be some kind of developmental problem in the baby, right? So that's what this question is helping you understand. This table here shows you ultrasound parameters, gestational age, and accuracy, right? So gestational sac diameter, crown rump length, and biparietal diameter, and all those other things that you could use at different points. So in the beginning, gestational sac diameter is the easiest thing to do. It's the most accurate, plus or minus 5 to 7 days, right? After that, it gets really bad and things get really, really disproportionate. This is plus or minus 14 days. So you're plus or minus 2 weeks. That's not very accurate, right? So key thing to keep in mind, very important to understand all that. Next question here, once again, we're looking at a graph here that looks very similar to one we looked at earlier, right? Which is this one. This was showing us fetal tachycardia. The baby's heart rate was really, 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 really fast. That's the top one, the fetal heart rate, right? Baby's heart rate was really, really, really fast. Contractions are occurring every so often, and it's nothing extremely concerning in this question per se, but it was concerning because she had pyelonephritis and it needs to be dealt with. Here, it's even more concerning. So take a look at this question. This time it's not labeled, but of course this is once again fetal tachycardia. 36-year-old woman, first pregnancy at 36 weeks gestation, is undergoing induction of labor due to preeclampsia with severe features, so she needs to give birth right away. She's receiving a magnesium sulfate infusion for seizure prophylaxis and an oxytocin infusion for labor augmentation. Great, so she's got magnesium sulfate, she's got the oxytocin. She had spontaneous rupture of membranes with clear fluid 4 hours ago. Okay. She had epidural anesthesia placed due to increasingly painful contractions and now has adequate pain relief. Great. She has a history of hypothyroidism that has been poorly controlled. That's not good. During pregnancy, temperature is really high, right? So she has a really bad fever. Blood pressure is high, which we know because that's what we're working with. She has preeclampsia. Pulse is 114, and the fetal heart tracing is given, which as soon as you look at it, the first thing you should realize is the baby's heart rate is super high. Right? So fetal heart rate is fetal tachycardia. The image actually tells you that the fetal heart rate is looking like, so the way you read this is, these are the numbers, 30, 60, 90, 120, 150. Then here you have about what is that? Can't really see the number per se. Let's make it bigger. It'll get blurry, but it looks like 180 and then 210, right? So she's at this baby is at 180. That's the 180 line. Right? If it goes higher up, if it was up here, this would be 210. If the line was over here, right, that would be 210 with the same squiggliness, of course. I couldn't do it like that up there. All right, so this is a fetal heart rate that's really high, and literally it's high, right? It goes up. So that's how you know. The normal would be between 120 to 150. Between 120 to 150. So normal would be like between here and around here. So you want it to be something in between this the whole time. Above that is fetal tachycardia. Below that is fetal bradycardia, both of which are, of course, problematic. All right. So that's something to keep in mind. So what is the most likely cause of a fetal heart rate tracing? Well, it's because of the fever, right? Any infection will cause fetal tachycardia. That's something you need to remember. There's an infection up here that was pyelonephritis, caused fetal tachycardia. The baby's heart rate goes up when the mom is in any kind of infection. Her fetal heart rate tracing shows fetal tachycardia, a fetal heart rate tracing with a baseline more than 160. Fetal tachycardia is associated with medication side effects and fetal hypothyroidism. The most common cause, particularly during labor, is maternal fever from intraamniotic infection, like chorioamnionitis. Okay, as the temperature elevation and increased metabolic demand create an elevated fetal heart rate, IAI, intraamniotic infection, which was actually the wrong answer choice for this other question here that people chose, but this mother wasn't exhibiting any symptoms of intraamniotic infection. Right? She didn't have those issues. She didn't even have preeclampsia really, right? She didn't have any of that. No chronic medical conditions. Everything was okay with her. Right? So her symptoms were different. She had pyelonephritis, which was evident from her tenderness over the right flank, right? Flank tenderness. That's where the ureter is. So the two questions are great for comparison. IAI occurs due to polymicrobial vaginal bacteria ascending into the uterus during labor. Patients have high fever, like her 103, in the absence of another clear cause, leukocytosis more than 15K, and or purulent amniotic fluid. The risk of developing IAI increases as labor progresses and after membrane rupture, as in her. Treatment is with antipyretic therapy, broad-spectrum antibiotics, and delivered to prevent fetal morbidity and mortality. So we're going to be learning about fetal heart rates a lot. Here we have fetal heart rate, undetectable amplitude. This is an absent fetal heart rate, right? So we're looking at different variabilities. This is minimal variability, moderate variability, and a lot of variability. So the variability is how high up and down is it going. It's about the amplitude of the waves, right? So you can see minimal to marked. There's bigger amplitudes here, right? So up here, clinical significance, abnormal or intermediate pattern. Etiology, CNS depressants, temporary fetal sleep, prematurity, or fetal hypoxia. Right, so these are bad. These are concerning. When there's minimal change, it's a little concerning. And if it's undetectable, then that's definitely concerning. Right, so if a woman has narcotic overdose or alcohol overdose, or if she's an opioid abuser, an alcoholic, you could see some of these. Normal pattern is right here. You get moderate changes, which is what you're seeing here. We are seeing moderate changes here, and then marked change is a huge change in amplitude, which could have many different significances, so it's unclear, but it's also problematic, and you need to figure out what's causing it. Right? So we're going to see more of that as we go on. And here's one last question about lupus in pregnancy. So right now, earlier we saw syphilis, we saw acute fatty liver, we saw pregnancy related exercise, pyelonephritis. So now we're going to be looking at this question regarding how does lupus look like in pregnancy. This is lupus nephritis, which, remember, we just looked at a nephritic issue, which was this one. This was hydronephrosis. This is normal physiologic hydronephrosis in pregnancy. Now we're seeing lupus nephritis in pregnancy. 26-year-old preemie gravid woman, 20 weeks gestation, comes due to joint pain and swelling in her hands and feet over the past day. She reports good fetal movement and has no abdominal pain, bleeding, leakage, or fluid, headache, or visual changes. So no reflex symptoms, which is great. She has a history of lupus, so they tell it to you in the question. That was managed with hydroxychloroquine, which she stopped taking prior to conception. All right. Today her blood pressure is really high, which is problematic. That's, and she's at 20 weeks gestation, so this is in the preeclampsia timeline. 150/95. 5 minutes later, following rest in the lateral recumbent position, it goes down a little bit. Fetal heart rate Doppler is 145, which is in the good range. Physical exam shows bilateral pitting edema and a red macular eruption on the cheeks. So we know her macular eruption must be from the lupus. The pitting edema, we're not 100% sure from. Lab results, we can see that UA is 2+ protein. So she has proteinuria and RBC Cas. Urine protein is a little higher than we would want it to be, and her creatinine is really bad. There's also high LDH, which shows cell death. Serum electrolytes, liver function tests, and coagulation studies are all normal. What is the most likely diagnosis? Very easy question. This is a lupus flare. She has a lupus flare. This was not preeclampsia, because if it was, then her blood pressure wouldn't really change just from positional changing. This patient at 20 weeks gestation has edema, joint pain, a malar rash, hypertension, and urinalysis with proteinuria and RBC Cas, all consistent with lupus flare complicated by nephritis, right? You don't get this RBC Cas stuff in preeclampsia, right? And you don't really notice that much protein until you do a 24-hour urine collection, right? Pregnancy and the postpartum period are associated with an increased risk for lupus flares, particularly patients with a history of lupus nephritis. Other risk factors include stopping of hydroxychloroquine and active disease prior to conception, which we wouldn't really know about, but it kind of makes sense. She stopped the medication that she takes for lupus, so of course she would have a lupus flare, right? You didn't need to know anything else about hydroxychloroquine to answer this question. Lupus is associated with increased risk of preeclampsia, preterm birth, cesarean delivery, fetal growth restriction, and even fetal demise. Lupus nephritis can be distinguished from preeclampsia by decreased complement levels and increased anti-nuclear antibody titers. And then here's a table with more notes regarding the clinical presentation and what can occur. So preeclampsia, although a potentially understandable answer choice, it did not fulfill as many things as lupus did. Remember what we spoke about earlier, that you could have two answer choices, A and B, and they could both fulfill a lot of the same requirements you're looking for, but one will fulfill more things, right? If we underline things for all the things that we have here, high blood pressure, that's both of them, right? Pitting edema, 2+ pitting edema, that's really just the lupus, not so much the preeclampsia. Macular eruption on the cheeks, that's also lupus, not the preeclampsia. 2+ proteinuria and RBC Cas, lupus, not so much preeclampsia, right? And then look at that, it's already pretty obvious the answer is lupus, not the preeclampsia. Her symptoms didn't fit the preeclampsia needs. So if you're on your test and you're looking at two answer choices that you're confidently stuck between, that's great. That means that you had good thinking and you arrived at two answer choices that made sense to some extent. Now you need to figure out which one makes more sense, or the better sense, or the more logically possible answer choice, and then go with that. All right, so that wraps up all of our questions over here. The one thing that we had skipped here was our concept of prenatal care, right? So prenatal care, generally speaking, we all have a pretty good understanding of prenatal care. The goal of prenatal care is to prevent, diagnose, and treat conditions that can lead to adverse outcomes in pregnancy. Expected weight gain, nutrition, and exercise recommendations are in this table. So we can see weight gain, guidelines for weight gain according to pre-pregnancy BMI. Underweight BMI, 12 to 18 kilograms. Acceptable, 11 to 16 kilograms. Overweight, when it's 7 to 11 kilograms. So for an overweight person, this is what's understandable. So what they're saying is, how much weight gain should you have depending on how much you weighed before you got pregnant? All right, so a person that is overweight, this is the most commonly tested. A person that is overweight should really only put on 7 to 11 kilograms during pregnancy, right? And if you're severely overweight, it's probably not a great idea to get pregnant. But someone with the BMI of like 35, for example, 33, they don't need to put on much weight at all when they're pregnant, and most likely are going to gain about 10 pounds, 5 to 9 kilograms. All right, so this is what this is showing you. You have to understand that some pregnant, sometimes what happens, and this is a cultural thing as well, sometimes what happens in pregnancy is that we eat more because people tell us that you're eating for two. We spoke about this in our last video. That is what actually is the reason this thing is so important. We need to tell our patients, you're not eating for two, just eat however much you would normally eat, or if anything, cut back if they're actually overweight, and don't be hesitant about cutting back what you eat. It is such a taboo topic to ever, in many cultures, ever tell a pregnant woman, oh, you should walk and exercise, light exercise, of course, not go skiing, and you should cut back on some foods. Oh, no, no, no. In India, I've seen that pregnant women are actually told to keep eating all day and just rest all day, which of course leads to terrible, horrendous consequences for not just the baby but the mom also, because then the mom delivers and becomes a pretty fat woman after delivering the baby, and that fat is not going to go away. It'll be ridiculously hard for it to go away, assuming she even intends to make it go away, you know. And these are some problems that are cultural things that we need to educate our patients about, so they can understand where the cultural clash is causing problems, right? And go home and educate their parents about it, because oftentimes, of course, this is a very difficult topic. If I was to tell my parents how I want to raise my kids and go against something that my parents are saying, then oftentimes parents are going to be like, oh, I raised you, I know what I'm doing, and you know, all kinds of answers like that, which are obviously very illiterate answer choices, because I don't know how you raised me. I wasn't watching. Thank God it turned out well. You know, and thankfully my own parents are very good at this kind of stuff, and they aren't silly about these kinds of things. They're very open-minded and understanding, but a lot of cultures, people get very offended if you try to teach them something they think they're very proficient at, even if you're a doctor. So you got to be careful in how you talk to them, but definitely do your part and recommend what you have to recommend, right? So if someone is severely overweight and they're putting on a lot of weight, they need to cut back on what they're eating, and they need to diet, and they need to exercise, right? Because it's going to be really bad for the baby. They're going to develop gestational diabetes, and then the diabetes is going to make the baby fat, and you know the case. Nutrition, the most important thing is folic acid. Folate supplements should start even before the woman is pregnant. She should start taking it when she's trying to get pregnant, right? Additional 100 to 300 kilocalories a day during breastfeeding, right? Just eating a little bit during breastfeeding, okay, to feel better, if anything. Iron, because of course you're making more blood, right? So you need more iron. Calcium, very important. Additional guidelines for complete vegetarians includes getting vitamin D and vitamin B12. Right? Very important to get these things. Exercise, 30 minutes of moderate exercise daily. Right? Of course, avoiding anything that can cause harm to the baby. Just basic 30 minutes of moderate exercise daily. So there's a lot of questions on these things throughout UWorld and whatnot. And you know, we looked at a table here to understand the exercise aspect of things, right? So this note, pregnancy and exercise, and that's basically it so far. All right. So now in the next video, we'll go into prenatal diagnostic testing.